Hello, everyone, and welcome to today's webinar, Documenting and Coding for Preventive Medicine Services, with emphasis on annual wellness visits. We're thrilled that you have joined us today. My name is Cassidy Avila, and I'm the Program Coordinator for the Texas A&M Health Rural Engagement Program. Please note that we are recording this webinar. A link to the recording will be shared with you via email about 24 hours after the end of this presentation, and that will come from the Rural Engagement Program. Following the presentation, we'll open the floor for a Q&A session. You're welcome to submit your questions anytime in the chat, either to me directly or to the group, and I'll make sure they're addressed during Q&A. Now, I'd like to take a moment to introduce our speaker, John Burns. Mr. Burns has dedicated over 25 years to the healthcare industry, focusing on auditing clinical documentation and ensuring compliance with coding and billing practices at Arch Pro Coding. He provides professional audit services, tailored training, and strategic guidance to clients nationwide. John also volunteers with the U.S. Department of Defense, contributing his expertise in compliance and auditing. John began his career in 1995 with an Atlanta-based consulting firm and later served as president and CEO of Modern Conventions and Compliance from 2004 to 2013. He then joined Doctors Management as a senior consultant until 2016 when he joined Arch Pro Coding full-time. John is a prominent instructor teaching evaluation and management documentation and coding, as well as rural health and community health coding and billing boot camps. Based in Georgia, John serves as Vice President of Audit and Compliance Services for Arch Pro Coding. His insights have been published in leading medical journals, including Coding Alert, BC Advantage, and Part B News. John's extensive travel has allowed him to assist clients in all 50 states and other locations abroad. John, it's a privilege to have you with us today, so please go ahead whenever you are ready.
Well, thank you very, very much, and welcome everyone. I'm going to have to shorten up that bio. I'm sorry I made you read so much.
No.
My name is John Burns. I am Vice President of Audit and Compliance with Arch Pro Coding. I'm thrilled to be here with you this afternoon to talk about a topic that's probably pretty near and dear to most of our hearts. To be honest with you, I think annual wellness visits in particular are oftentimes misunderstood, even by patients. And I think that word annual kind of throws people for a loop sometimes because you get them confused with a complete physical. And one of the things I want to make sure that we get across over the next 45 to 50 minutes or so is the fact that they're not the same thing. An annual wellness visit and a annual physical exam, they're not the same thing, although they're oftentimes spoken of in the same breath. And I'm hoping that I can shine some light on what it is and what it is not. If we went back prior to 2000, prior to 1996, we'd actually find that the Medicare program did not pay for any preventive services prior to 1996. Started with the Balanced Budget Act, and they paid, they started recognizing and paying for clinical breast exams and pelvic exams, and then PSAs. And over the years, the list of approved preventive services that the federally funded health program, being Medicare, pays for, that list continues to grow each and every year. And there are a number of those preventive services that I will talk about with you during our time here together. Not all of them. There will be a focus on the annual wellness visit and, of course, the IPPE. I don't think that we get them confused, but it's based upon frequency and timing in terms of when and how we report them. So we'll talk a little bit about the documentation and then, of course, the coding and the billing piece that need to coincide with it. This slide here is just a little reminder for you, you folks out there that are social media gurus. Like us on our Facebook pages, Instagram. It is one of the vehicles that we use to keep our clients up to date with changes as close to real time as possible. As you well know, there might be something that changes this afternoon that we don't find out about until we get back to our desk tomorrow. So social media, it is a platform that we use to just kind of keep people up to par with changes as those changes do occur and take place. So I'd urge you to take advantage of that. I've already given you this. One thing you might not have is my email address. This is a way to contact me. I travel quite a bit. I'm on the road more sometimes than I want to be, but give me a couple of days to get back to you. I'll get back to you as quickly as I can. I will not leave you high and dry and out there to dry. If there's something I can help you with after this program or something that you're interested in a little more information on, I'd be more than happy to help you in any way I can. So again, take note of my email address there. I do believe that the slides will be shared with you, and I know that this session is also being recorded. So I think that's really kind of all of our housekeeping here. We're slated for an hour. I've kind of tried to focus this on about 45 to 50 minutes of actual talk time so that we can leave plenty of time for questions and answers if they do exist when we're finished up here. So there's some of my credentials. I won't bore you with them. And again, I think I'll shorten up that bio sometime because listening to all of that, it might be a little excessive. So again, welcome. Thanks for being here. I have to make a couple of disclaimers before I can really get in and dig in, especially when we're talking about things like this. I've got to give credit where it's due. So all of the program, all of the information within this program, it is presented by Arch Pro Coding. It is designed by us based on research and our experience. I've been doing this for almost 30 years now. And I'm offering you my opinion and my advice from a consulting perspective using CMS as my foundation. All right. We can't accept liability for errors, omissions, misuse, or misinterpretation of the content. What you'll find in these slides is in one way, shape, or form taken directly from the Centers for Medicare and Medicaid Services and various tools and resources that we have at our fingertips that I'm going to share with you as well. There are hyperlinks that you'll find throughout the course of the program. Most of them are going to be highlighted by a little icon that it's a square with a little two-link chain link in it, suggesting that there is a hyperlink there that you can actually reference some of these tools and resources at. And of course, I have to make this last disclaimer. When I talk about CPT codes, I have to give credit to the American Medical Association, who authors all of this content. And in this manual, just because there's a code for something does not mean that it's always going to be paid for. For those of you I've worked with, and maybe some of you that have attended some of the boot camps that we've actually offered out there in the great state of Texas, I will be the first to tell you that this manual is a guide, but the AMA is not really interested in whether we do or don't get paid. I don't think that's their priority. They want to make sure, the AMA wants to make sure that we have a proper way of reporting to our insurance companies and payers the professional services that our that our providers are performing, whether they're payable or not. And something I always like to point out, being in the introduction of that CPT, is something that the AMA prints each and every year. And it's actually the last sentence in the second paragraph under the introduction. Before it even gets into any of the codes in the manual, the AMA literally states that inclusion or exclusion of any procedural code or service does not imply any health insurance coverage or reimbursement policy. Now, you may be scratching your head and saying to yourself, why would the AMA say, we don't care if you get paid? Because of what I just said. What they've been commissioned to do is provide us with a tool and a resource to give us the ability to report what our providers have done. But payment comes directly from payers and payer and participation agreements. And each payer with whom you participate, they may have different rules as it pertains to the things that we will discuss. But most importantly, CPT, it is a registered trademark of the American Medical Association. All of its nomenclature and features and symbols and text, everything is owned by the AMA. We at Arch Pro Coding do not claim any ownership or authorship of the content therein. So now that I've done what I need to do in terms of making my legal disclaimers, we can really kind of jump into where all of this started. And we have to go back to the 1960s to really kind of talk about the establishment of Medicare, but with it came no payment for preventive services. There was really more of a focus on what do we do when patients get sick? What are the codes for procedures, services, and evaluations that may be performed out there? In fact, we didn't even have E&M guidelines in CPT until 1992. I don't know if you're aware of that or not, but it was primarily initially a procedure and service only kind of manual. It wasn't until the 1980s that there was even chatter about preventive services being paid for, and it started with mammograms and pap smears for cervical cancer screening. And then there was a massive expansion of preventive services that includes certain things like the flu vaccine and the pneumococcal vaccine, the Hep B vaccine, certainly COVID, not back then, but is now. So in the 1990s, under the Balanced Budget Act and under the Clinton administration, there were a whole lot other services, digital rectal exams and PSAs. And over time, through the Medicare Modernization Act and through the Affordable Care Act, there have been enhancements to the preventive services, to the list of preventive services that are recognized by the United States Preventive Task Force and that CMS has actually approved for coverage. And as of today, there is a whole slew of services that are qualified as, we'll call them preventive services, meaning that there's not a chief complaint or presenting problem, where Medicare will actually pay for these services without or even in the absence of active disease or manifestation or signs or symptomology. So I'm going to provide with you or to you a link to something that's referred to as the preventive service charts. Now, I'm assuming that on this call, much like in the programs that I've spoken at out there in Texas, I have to assume that I've got probably a healthy mix of both RHCs and FQHCs. And I'm going to focus most of this conversation on RHCs and FQHCs, of course, and for that reason. But there are some differences and discrepancies between the two organizational types and the way that certain services can be and should be reported. Preventive services, the way that they should be reported may differ based on what type of facility or organization you represent. The primary focus is going to be preventive physicals, IPPEs, and annual wellness visits, although I have scattered in a few other preventive services that I think you may find helpful and beneficial, which is why I included them in the slide deck here. Now, the services that we find in CPT's manual, and it starts, if anyone had a CPT and you were following along, you could find it on page 39 of that manual. But this is where we see the codes for preventive services, which range from 99381 through 99397. So these are the codes that the AMA has included as they relate to physicals in CPT. Now, the question I'll ask, and I know the answer to it, many of you probably do too, but what does Medicare pay for an annual physical might be the best way to pose the question. And the answer to that is no, they do not, they have not, they never have, and potentially may never in the future. I can't say that, who knows? A complete annual physical is something that could down the line become a standard Part B Medicare benefit, but I have to be honest and say, I don't really know whether that's going to happen or not. To this date, it has not. These codes that we're looking at right now, ranging from 99381 through 99387, they are reserved for preventive services. They are AMA codes, but these are not Medicare, traditional Medicare standard covered benefits. These are age specific, and they're also specific to patients being either new patients or established patients. We'll get into that in a moment. But these codes are intended for physicals. Medicare doesn't pay an annual physical. So the question is, well, if we perform an annual physical for a Medicare patient, how is that reported? Well, it's with one of these codes, but guess who becomes responsible for the payment of your fee? That becomes the patient, because it's a non-covered service and not something that is, the patient is not protected by Medicare's fee schedule for something that Medicare does not cover. So hopefully that makes sense. Now, 99381 to 87 are for new patient preventive medicine services. The 99391 through 97 are for established patients. So it's fair to say that the fifth digit of the code identifies the patient's age, and you can look in the checkbox, the little box and diagram I have here on this slide for you, to make sense of that. But the fourth character of that code, or the fourth digit of that code, if it is an 8, we're talking about a new patient. If it is a 9, we're talking about an established patient. So now we have to make sure we understand what the difference is between a new and established patient. And don't get frustrated with me yet, but the definition of a new patient is different for those of you representing FQHCs and community health centers than it is for anyone else, anywhere else on the planet. FQHCs have their own definition of new patients that has been kind of pushed down our throats by CMS over the years, and there's reasons for it. Of course, there's money behind it, and it'll make more sense in a few moments. But a new patient, according to CPT, who again does not pay us, the AMA doesn't pay healthcare claims, but the AMA has created these codes in their manual specific to new or established patients based on their definition of new and established patient, which can be found on page 4 of CPT. And here's what it reads. A new patient is a patient who has not received any professional service from a provider or any member of the provider's group in the same specialty or exact same subspecialty in 3 years' time. That's the definition from the AMA. But if we looked into section 40 of chapter 13 of the Medicare Benefits Policy Manual, it specifically says there, for FQHCs, a new patient is defined as one who has not received any payable medical or mental health service by any FQHC practitioner in the previous 3 years. So the 3 years is consistent. But if you notice, the AMA's manual says, well, a new patient, if we had a disciplinary group and we had a psychiatrist and a primary care provider, both of those providers could bill the same patient as new patients, even though they're billing under the same federal tax ID number. And the answer is yes. In a fee-for-service environment, that's the way it's intended. But for Medicare purposes, for those of you in FQHCs, the patient's or the provider's specialty or subspecialty does not mean anything from a reporting standpoint, because Chapter 13 specifically says once that patient receives a professional service from an FQHC provider, regardless of specialty, they become established with all of the providers working within that organization, that group, or under that federal tax ID number might be the best way to explain it. So what Medicare does, and here's that little link here, okay? This is the symbol. Anytime you see this throughout the slide deck, you can assume you see little Pillsbury Doughboy's hand coming in here. If I were to click on this, which I'm not going to right now, it would take me exactly to where I have a snapshot of what you'd be looking at the website. But all of the documentation requirements for IPPEs and annual wellness visits will be found or can be obtained simply by clicking on this particular link. But what I want to point out first is routine physical exams, which are reported using those CPT codes we just briefly pointed out. These are exams performed without relationships to current treatment, diagnosis, injury, complaint, signs, symptomology, whatever the case may be. And it says Medicare does not cover a routine physical, and the patient is responsible for 100% of the out-of-pocket costs. This is directly from CMS and something that if you need, can share with your patients, because some patients, and I know that some patients have probably looked at you over the years and said, well, hey, I've got Medicare, they pay for everything. We know that's not true. And we have to let our patients know that an annual wellness visit, which we'll talk about shortly, and a physical are not the same thing. In fact, what Gary Lucas, our Vice President of Education and Research, he and I have always kind of referred to this annual wellness visit as being a keep your clothes on physical. It doesn't require a physical exam like those age and gender appropriate physical exams that are standard to a routine physical exam. So they're different. And there are timeframes in which they can be reported. And more importantly, there are documentation requirements that must be met. That's one of the main purposes of all of us having an opportunity to be together here this afternoon. So again, there is a link here that you can follow to Chapter 18 of the Medicare Claims Processing Manual, which is specific to preventive and screening services. Now, here's what I have to caution you caution you about. Chapter 18, the preventive and screening services. This manual or this policy manual is not specific to FQHCs and RHCs. This rather pertains to everyone straight across the board as it relates to preventive services that the Medicare program pays for. But there's not a focus on FQHCs or RHCs. But what FQHCs and RHCs do have, and what CMS has provided us, is what I'll provide you access to shortly. They're called preventive service charts. And there is one that is referred to as an RHC preventive service chart and another that is an FQHC preventive service chart. There are a few distinctions between these two policy documents, but the most important thing that I need to mention is the fact that the IPPE and the annual wellness visit, these are codes that you are not going to find in the CPT manual. These are Medicare specific codes. And typically, if we're talking about Medicare specific codes, we're going to find them in the supplement to the level 1 code set being the HCPCS level 2 codes. So CPT codes, you're not going to be quizzed on this, but I'll throw it out there anyway. CPT codes are level 1 codes. HCPCS level 2 codes are level 2 codes. These level 2 codes all begin, this is how you can tell them apart. These all begin with a letter or an alpha character, whereas level 1 codes all begin with a numeric character. So just by looking at the code, you should be able to determine whether you're going to find it in the level 1 code set or the level 2 code set. So with that being said, this is a list of the preventive services that Medicare pays for, but this is not specific to the RHC and FQHC communities. The preventive service charts we'll talk about shortly are tailored specifically to you. So the first thing we're going to talk about is the initial preventive physical exam. We love to call it, well, I'd like to call it the Welcome to Medicare physical. It is the only physical exam that the Medicare program is ever going to pay for, by the way. This is the one physical that Medicare will pay for, but guess when it needs to be performed? And don't let your nurses do this. Obviously, our RNs and LPNs can't perform the physical exams of these patients anyway, just by law, by licensure, by certification. An RN is not qualified to perform, aspects of a cardiovascular physical exam, for example. That's something that is limited to qualified healthcare practitioners. But the documentation requirements for these IPPEs requires first documentation of the patient's medical and social history, including family history where applicable. The provider must document a review of systems. Now, something with regard to the review of systems, you might say the review of systems, a 14 system review of systems is performed and grossly negative. That'd be perfectly appropriate. But if there are any positives with regards to those, they should be clearly documented within the subjective category or portion of the SOAP note. But to perform a review of systems is a requirement. There is not a requirement for a certain number of systems to be reviewed, but a review of systems is required along with patient's past family social history. Conducting a physical exam that is relevant to the patient's age, gender, and medical history. This is one of the things that really sets the IPPE apart from the annual wellness visit. This bullet point of a physical exam relevant to the patient's age is not applicable. You'll see shortly when we talk about the annual wellness visit that outside of the patient's height, weight, blood pressure, and BMI, those are vital signs that essentially need to be documented for the annual wellness visit, but not a formal physical exam is not required in those cases. I'm sorry to keep itching my face, but the pollen here, I don't know what it's like there in Texas right now, but the pollen in Georgia is something awful. There must be a documented assessment of the patient's functional ability and ability to carry out daily acts of living. There must be documented a list of the patient's current providers and suppliers or other healthcare practitioners and providers that are associated and a part of the patient's care. And again, these documentation requirements I'm sharing with you, I've pulled directly from the documentation requirements at CMS's website specific to the IPPE. So you can use the data or we'll say the data points that I provide in this presentation. You can use these to kind of cross-check the templates you may be using internally to make sure that there are none of these requirements from a documentational perspective. There are none of them that you're kind of missing the boat on. The coding guidelines, the IPPE in and of itself is reported using G0402. Again, G indicates we're not going to find it in CPT, so don't look for it there. It's going to be in the HCPCS Level 2 codes book. There is a screening EKG that can be coded using codes G0403 through G0405, depending on the components that are being performed. But that is to be reported separately when performed. G0402 is for the IPPE visit and that IPPE visit alone. It does not include the EKG. Sorry to sound redundant there for a moment. Additional codes may be used for any additional services that are performed throughout the visit, whether they be vaccines, screening tests, vision screens are a big one. Now we could leave it there for now. Ensuring that all services are documented to support that the codes are billed. That brings us right back here, folks. All of these bullets must be included within the framework of the templates that providers are using to capture those. The IPPE in terms of billing is only payable one time in a beneficiary's lifetime, and it must happen and must be performed within the first 12 months of their enrollment. The requirement here used to be within the first 6 months. It was expanded about 5, 6 years ago would be my guess, but it was expanded a number of years ago. And Medicare beneficiaries can actually qualify for the IPPE, this one-time benefit, within 12 months of their enrollment. It does not include any ancillary diagnostic or lab services. They are to be reported separately when performed. And providers should familiarize themselves, I say, with that Chapter 18 of the Medicare Preventive Services and the Medicare specific preventive service charts that are out there for FQHCs and RHCs. And I'll point those out to you and show you the hyperlinks to those documents in just a few moments. Now, the annual wellness visit is a whole lot different than the IPPE because the annual wellness visit is one that is performed after the benefit of the IPPE has been exhausted. And it must be 11 months and 30 days that have passed. I say 11 months and 30 days, a minimum of 11 months, but I don't want to complicate things here. I like keeping things simple whenever I can. So if today on April 30th, the patient receives their IPPE, they will not qualify for the initial annual wellness visit. I would not suggest scheduling it before April 30th of 2026 because a lot of times we find that things get billed twice within the same time frame when it's only allowed once. And the second one, it gets kicked out and it denies and rejects as a result of a frequency violation from a billing standpoint. The annual wellness visit has two codes, unlike the IPPE, which is G0402, and only payable once in a patient's lifetime and within 12 months of their enrollment. The annual wellness visit is subsequent to the IPPE. And if the patient never gets the IPPE, they just lose that benefit after the 12 months, first 12 months of their enrollment has expired. So now, with that being said, the annual wellness visit has two different codes. There's one for the initial annual wellness visit that is reported using HCPCS Level 2 code G0438. And it is payable, similar to the IPPE, only once in a patient's lifetime. And then after that, each subsequent year, G0439 for the subsequent annual wellness visit becomes reportable, payable, billable, or becomes reportable and payable each year subsequent. So you get the IPPE only once, the initial annual wellness visit just once. And then it's subsequent annual wellness visit, G0439, from there on out as applicable. So what is it that needs to be documented for the initial annual wellness visit? A health risk assessment, a list of current providers and suppliers, patient's medical and family history. Social history typically is documented within this framework as well. Vitals, BMI, cognitive impairment screening, a depression risk assessment, typically using a standardized tool, which is typically the PHQ-2 or 9. Risk for falls and a functional status assessment must be evident or documented in one way, shape, or form. And there must be a written schedule for the following 5 to 10 years in terms of those benefits that the patient should be considering based upon the history that's been obtained for them. Now, there are codes for advanced care planning. They're 99497 through 98. Those codes are payable or are reportable when performed, and optionally, they can be billed and payable separately as well. The subsequent annual wellness visit is very similar to the initial annual wellness visit, but we're going to use a different code, of course. And what we're really doing here is we're simply updating what we did at the initial annual wellness visit. We're updating the health risk assessment. We're updating the patient's providers and list of current suppliers. We're updating their history and updating their vitals. Depression risk assessments, again, need to be updated and performed. That written screening schedule for 5 to 10 year period of time, and potentially and additionally build advanced care management, an advanced care planning code is also separately billable when documented. So those are the two codes that are appropriate for the annual wellness visits, not to be confused with the IPPEs, and that is how they are to be reported. Now, for RHCs, this is just for the RHCs that I have on the line. This is a link that I'm going to follow this and I'll kind of show you this, but there are preventive service charts that are covered. There's a slightly different list for RHCs than FQHCs. So for those of you in the FQHCs, bear with me for a moment. I'm going to click this little hyperlink and it's going to bring us, hopefully you can see what it is I opened up to. You can see this hasn't been revised since 2016, but it's the best document we have to play with and to work with. But when you look at this document, what it does for RHCs, it says if you want to qualify for the all-inclusive rate payment for an IPPE, here's the code you use, a brief description. It will be paid at the all-inclusive rate. Is it eligible for same-day billing? This is unique to RHCs. FQHCs disregard this. You're able and permitted to report the IPPE in a rural health clinic on the same day as a medical or mental health visit. They represent separately billable encounters, and you could be paid more than one all-inclusive rate. Patient's coinsurance and deductible is waived. In the far right-hand column of these preventive service charts, you'll see where Chapter 9 of the Medicare Claims Processing Manual and Chapter 18 that we talked about earlier of the Preventive Services Manual, these are simply references that CMS provides to say, hey, listen, if you have any other questions that pertain to this IPPE, refer here. So it's just a snapshot and a really, really cool tool, but this gives us a list of all of the preventive services that are payable in RHCs and whether patients' coinsurance and deductible is waived. It's not waived for everything. Like for glaucoma screens, if applicable, patients' coinsurance and deductible are not waived for them, nor are they for prostate screening. But typically, patients' cost insurance or cost sharing, coinsurance, deductible, they are waived for most preventive services. If anyone ever told you that Medicare waives coinsurance and deductible for all preventive services, that is not true. There are exceptions to that. So that's the list of codes as it pertains to, that's the list of the codes as it pertains to our RHCs. And RHCs will be paid the all-inclusive rate for eligible preventive encounters, and typically patients' coinsurance is not applicable, nor is the deductible for most Medicare preventive covered services. And you can see here that except for the IPPE, all services performed on a given date of service represent a single service or a single visit, a single encounter. But the IPPE is the exception where you can report the IPPE along with a medical visit or a mental health or behavioral health visit on the same day, and they both would represent payable services at the all-inclusive rate. Now remember, I said that's for RHCs specifically. These are snapshots of what I just took you through, or to using that hyperlink. Now, if we're talking about FQHCs, there's a little bit of a difference here, all right? This is a link similar to the other, and just to show that I don't have favorites, I'll show you your qualifying visit list. But remember, this is specific for FQHCs, your preventive service chart. And you'll notice that deductible is not mentioned over here. You'll notice that there's something about a 34% increase in a PPS rate. What's a PPS rate as opposed to an all-inclusive rate? That's why you have to make sure you're using the appropriate or proper tools here. Because what we've actually found is that there are instances where folks might report something in an FQHC the same way that someone might say to a commercial insurance plan or from an RHC, and claims reject because there are special rules that kind of govern FQHCs. The preventive service chart does a good job of illustrating some examples of that. So for the IPPE, there's the code, there's the description. There's nothing different from the chart we looked at for RHCs. But here, rather than all-inclusive rate methodology, it's paid under the PPS rate. For those of you that might not know, they're very similar concepts, but RHCs and FQHCs are typically paid a lump sum amount in the form of an all-inclusive rate, or AIR for RHCs, or a PPS, prospective payment system amount, to FQHCs. They are very similar in that they represent per diem payment rates. You get X dollars for a qualifying visit, is kind of how we can look at that. But check this out over here on the FQHC chart where it says increase in the PPS rate by 34%. What that means is, yes, you're getting 34% more money for this IPPE, you're getting 34% more money than you would, or you're getting 34% for an IPPE, and there are two other exceptions. You in FQHCs, you get 34% more money on, as you can see here, the annual wellness visit. For the annual wellness visit, there's those codes. That is qualified for same day billing. It qualifies for an increase to the PPS rate of 34%. But notice that that's not for most services. It's only the annual wellness visit and the IPPE that allow for this 34% boost in the PPS payment rate. Now, those of you in the RHCs might be saying, well, that's not fair that they get 34% more money for an IPPE or an annual wellness visit. But at the same time, the FQHCs might have said a couple of moments ago, well, that's not fair. RHCs get to bill for an IPPE and a medical or a mental health visit on the same day. But those are two of the ways that RHCs and FQHCs are viewed differently from a preventive service standpoint. These charts are absolutely, I think, they're imperative that you have access to them. And if you're in an FQHC, please don't pay any attention to an RHC preventive service chart. Now, as of January of 2016, FQHCs are paid under this PPS rate. And again, mostly for primary healthcare services and behavioral and mental health services. Typically, all the services that are performed are going to be inclusive in one PPS payment. But there are, like we just talked about, increases of 34% when either a new patient visit is performed, an IPPE, or an annual wellness visit. In those three instances, FQHCs are entitled to 34% more money when those services are reported with what I like to call the magic G code. Some of you have heard me say this, I think, in the programs that I've taught, but there are 5 G codes that range from G0466 through G0470. One of those 5 codes, along with a code from the qualifying visit list, must be included on the UB, on the claim, in order for you to be paid that 34% increase. In order for you to get the PPS rate, one of those G codes must be used. If it's a new patient visit code, or if it is an annual wellness visit or an IPPE, you will notice a 34% increase in what that PPS payment rate is for that particular encounter. All right. And this is a snapshot from the preventive service chart for FQHCs that I pointed out to you just a couple of minutes ago. I don't need to kick that horse any longer. I think we'll just move on. It's just a snippet from that preventive service chart that we took a look at earlier. Here are those magic G codes. Again, for those of you in RHCs, pay no attention to this. For those of you in FQHCs, look at that G0468. That is the magic billing G code that you must report on your claim along with the IPPE or the annual wellness visit to qualify for that 34% spike in the PPS payment for those services. I mentioned the importance of the Medicare benefits policy manuals. If you look in the Medicare benefits policy manual for the IPPE and the annual wellness visits, there's some really helpful information there. And it says the IPPE can be billed as a standalone visit if it is the only medical service provided at the date with a qualified practitioner. So that tells you right out of the gate that the G0402 is intended for use by an MD, by a doctor or a qualified practitioner like a nurse practitioner or a physician assistant. I think we can all agree on that. I think we all know that there is a way to qualify for additional money to the PPS rate when it is reported along with the appropriate G code, that being the G0468. And IPPE and another covered visit are separately payable for RHCs, but not for FQHCs. When we move down here to this next slide, the annual wellness visit, it can be reported as a standalone visit if it's the only medical service provided on that day with a qualified provider. And FQHCs have to report that G0468 along with the annual wellness visit as well. RHCs certainly do not need or are not required to report a modifier. But what I want to mention here with regard to the annual wellness visits is I've seen where there are certain, I'm not going to say people, locations, or names, but where annual wellness visits are being reported when the patients don't have face-to-face visits with a qualified practitioner on a given date. In a fee-for-service setting, let's say that, let's say I were a clinician at the corner of Fifth and Main, and I'm seeing a Medicare patient and providing, I'm providing an annual wellness visit. If I allow my nurse to see that patient, but I don't have a face-to-face visit with that patient on the same day, if that is in alignment with what the nurse is licensed and certified to do in a given state, they could actually do the work of the annual wellness visit and it could be reported as such, not in FQHCs and RHCs, because FQHCs and RHCs, according to Chapter 13 of the policy of the Benefits Policy Manual, it says there must be a face-to-face visit with a qualified practitioner. Who is a qualified practitioner? A physician, a nurse practitioner, a physician assistant. There is a longer list in Chapter 13 of providers who are recognized, but a nurse-only visit does not qualify for a billable visit in FQHCs or RHCs. So if there's not a face-to-face with a qualified provider, the annual wellness visit is not reportable to Medicare out of RHCs and FQHCs. I hope that makes sense because it's a really important concept. And I'll just say this to kind of caution you a little bit. If you encounter a patient who has an annual wellness visit performed and it is being primarily performed by staff, but the provider does not have a face-to-face with the visit with that patient on that date, the annual wellness visit should not be reported. You cannot capture the all-inclusive rate or the PPS rate without a face-to-face encounter. The only exception to that would be in terms of telehealth. The face-to-face encounter, audio-only telehealth probably provides the only exception to that rule that is specific for RHCs and FQHCs. I work with private practice providers as well, and we talk about this code called 99211. I don't speak with my RHC and FQHC folks much about the 99211 for the simple fact that it's not payable as an encounter to Medicare. It's not a payable Medicare encounter because they don't, the 99211 doesn't require that face-to-face with a medical provider. I would certainly caution you to avoid these pitfalls with regards to the IPP and the annual wellness visit. Trying to report something as an annual wellness visit that's actually a physical or vice versa, just make sure we understand that a physical is not an IPPE and an IPPE is not an annual wellness visit. We have to understand that those are three different things. They are limited in terms of the frequency in which we can report them. We strongly encourage that a visual acuity screen be documented at the time of the initial preventive physical examination, and that patients' PPPs or personalized prevention plans are updated at each subsequent visit. Missing documentation, obviously, we all know I'm not going to, if it's not documented, it's not done. I think that we're all pretty clear on that. Use of modifiers or certain code pairs are common issues here. If you try to bill for an annual wellness visit and a sick visit on the same day, you're not getting paid for both of them. And trying to collect money from patient when maybe their coinsurance or deductible, if applicable. If they're waived, we can't charge patients for things that are actually waived by statute. All right. Now I'm going to flip through a few other codes. We've gotten through the two key pieces of this program, being the annual wellness visit and the IPPE, but there are a few others I decided I wanted to share with you. First being the G0101, which is a code that is actually used to report a clinical breast and pelvic exam. It is payable for women every 2 years, women over the age of 39, every 2 years. It is intended every 2 years, but it's actually payable once every year for a woman who lies in a high risk category. Here are those high risk categories and the diagnoses that go, that may go along with them. But if there's early onset of sexual activity or more than 5 sexual partners in a lifetime, or her personal history of sexually transmitted disease, personal abnormal PAP is actually another prenatal exposure to diethylstilbestrol, and then fewer than 3 negative or any pap smears within the previous 7 years also qualifies as high risk when diagnostically those codes would allow for that G0101 to be payable once every year as opposed to once every 2 years. Now, here are the 11 documentational elements that are associated with the G0101. of which a minimum of 7 must be documented to qualify for payment for G0101. There's nothing that says which 7 they need to be. Some providers routinely document all 11 if applicable, but at least 7 of these 11 elements, according to CMS, must be documented to qualify for payment for the G0101. Smoking cessation. This is another one that I've talked about for a number of times. A lot of folks aren't aware of the fact that Medicare will actually pay for 2 quit smoking or 2 tobacco cessation attempts per year. Each attempt includes up to 4 visits. So it's conceivable that the Medicare program would pay as many as 8, so 4 visits per 2 sessions, as many as 8 PPS or all-inclusive rate payments. If documentation supported tobacco cessation up to 8 times per calendar year. That's a lot. But what must be documented is time. The smoking cessation codes, there's 2 of them. There's 99406 and 07. They're referred to as intermediate and intensive. Here's what they mean. Intermediate means 3, but up to 10 minutes, because an intensive cessation counseling visit is greater than 10 minutes. So what does that, the definitions of these codes, what does that tell you right out of the gate? Must be documented? Time. And if less than 3 minutes is documented, you cannot report a smoking cessation service code. And these are the diagnostic codes that are typically utilized in these cases where smoking cessation counseling visits are being reported. These are some of the more common Z codes that we are going to find that relate to some of this preventive medicine service stuff. You can see that they are Z codes. Now, some of you may have heard, and it might be review for some of you, but I have to mention it because I've had people, even as early as last week in Michigan, I've had people say to me, we're not allowed or permitted to use Z codes as principal or first listed diagnostic codes. And I'm like kind of blown away there because I think to myself, why would anyone ever give you that advice? If a patient comes for an annual wellness visit and there's no symptomology or underlying conditions or diagnoses that pertain to that day's care, what other code would you use? It's not like you can make something up. So the point I'm going to make is this. Here are some of the more common diagnostic codes that align with these preventive services that are oftentimes reported in FQHC and RHC settings. But these codes can and often, very often, are used as principal and first listed diagnostic codes. The Z codes that cannot be reported as principal diagnostic codes are those ranging from Z55 through Z65. Those are the ones that are intended or reserved for social determinants or social drivers of health. They should never be principal. But don't allow yourself to be convinced, even if someone says you can't use a Z code as a principal diagnostic code, that is not true. You most certainly can. It's just that not all of them are intended for principal or primary code use. And the SDOH codes are a perfect example of those. Now, just a couple of little snippets here to give you an idea. This is a non-Medicare patient, 45 years old. Male comes in for his annual physical, doesn't have any signs or symptomology at the time. An age and a gender-appropriate history and physical are being documented. The patient's getting a refill of their lisinopril because they're diagnosed as having hypertension. Blood pressure reading today was 118/78, so obviously it's, we'll say, stable, I guess would be a good way to put it. So how would this be reported? Well, we'd use the code from CPT, age specific. For a 40-year-old, it would be 99396, which is for patients aged 40 through 64. So for this patient, it'd be 99396. The diagnostic code would be Z00.00. Why? There were no abnormal findings. But yes, a secondary code that should be reported in that case is I-10 to speak to the fact that we refilled that patient's lisinopril at the time of that visit. There was nothing abnormal about it. We're just refilling their medication. And that's the way that it would actually be reported. If your charge is $150, the patient would be responsible for paying $150. So again, Medicare doesn't pay for a physical, but there are a lot of other insurance plans, of course, as you know, that do, and many Advantage plans that do. So each payer is specific to their rules here with preventive medicine, and I can't emphasize that enough. Make sure you check with your payers to make sure that you've got everything in line. For an RHC, We got a 65-year-old male coming in for a physical. They began receiving their Medicare benefits roughly 7 months ago. So I want you to think of, okay, well, maybe this patient, maybe they qualify for the IPPE because that has to be in the first 12 months of enrollment, right? But he's also complaining at this time of right lower quadrant abdominal pain for which separate documentation supports detailed history, let's just say appropriate history, physical, and a moderate complexity of decision making. And an order for an ultrasound was written. How would that ultimately be reported? Well, in this case, remember the IPPE and a medical visit can both be reported on the same day for RHCs, not an FQHC, but for an RHC, the way that would be reported is we'd have the preventive service code for the IPPE along with the Z00.01. Why would it be 01? Because there was an abnormal finding of right lower quadrant abdominal pain. That's what this diagnosis is used to report. So the 99214, based on moderate complexity decision making, would be reported as well along with the CG modifier and 25 modifier to say that it was, say, separately identifiable from the IPPE that the patient received same day. And guess what? This is going to generate two different all-inclusive rates. But that would not be the case. The same would not be the case in an FQHC. In the FQHC, what would be reported is simply the G0468 and the G0402. This is the magic billing code. But this G0402 is for the IPPE. So it's really the same thing as we looked at and talked about on the previous slide for RHCs. But remember, FQHCs are not permitted to report an IPPE and a sick visit or a behavioral mental health visit on the same, a medical or a mental health visit on the same day. But this patient, they haven't received their IPPE. It says here, all necessary subjective and objective components were adequately documented in the medical record, and the patient here exhibited with no additional complaints. So here, it was Z00.00 that was used diagnostically. And of course, the reason for that, there were no abnormal findings found for this particular patient. Let's say we looked at this in, my last slide here, I promise. If we look over here at this slide, let's say that this was for an FQHC. Do you know how that would actually be reported? It'd be reported exactly the same way. So this scenario we're looking at on this slide here, where the patient had the right lower quadrant abdominal pain and a moderate complexity of decision making. For an FQHC, we would not be permitted to report both of these codes. That's an RHC only benefit. But in the FQHC, it would be reported this very same way. But guess what would happen now? This would become Z00.01. Because why? Because there would have been an abnormal finding in that particular instance. So it looks like we've got about, to me, it looks like 7 minutes to spare. I am going to take and field questions as they are either fed to me or Cassidy. I mean, if you want, I'm more than happy to get into the chat box and find them myself. But if you want to throw the question to me, I'm more than happy to address it to the best of my abilities. And what you're looking at here, folks, on this last slide is once again a link to our website, my email address, and on the left-hand side, all of the tools and resources that I used in order to put this program together. And they are hyperlinked, so you can use these hyperlinks to take you directly to those references and tools. So thanks again for having me. I'm going to wait for question number 1, and we're going to go for there.
Yeah, that was excellent, John. If you, the first question is a bit long and it has multiple questions within it. So you might want to put in the chat.
What time did that one come? Oh, okay. I think I found it. 119. Is that the one?
Yes.
All right. Let me just take a question here. I'm going to paraphrase it with you. Not a question to derail. Okay. Our providers are very unsure as to what their role is with the annual wellness visit. Do they do a physical exam or not? All right, that's a great question. We can answer that one easy. I'm going to answer that part first. Actually, I can answer both questions here kind of in the same breath. What role do they have to play? Those documentation requirements that I pointed out earlier in the program with regards to the annual wellness visit, each of those bullets would have to be documented. So they'd have to document the patient vitals. But the actual provider, the qualified practitioner, would not need to prove anything other than that there was indeed a face-to-face visit. And I know that some people are like, I just have the provider walk in the room, say a quick hello, and it's documented in the chart that's seen with Dr. So-and-so. That's one way to handle it. But there is nothing scientific with regards to what the provider must or must not document. I would suggest that at a minimum, that the provider verify that there is indeed no sign, symptomology, or say, HPI element or chief complaint that should be worked up on. And it goes on to, you go on to say here that do they do a physical exam or not? I would say that you're not going to do the physical exam outside of vitals and the BMI because it's not required for the annual wellness visit. That's why I call it the keep it the clothes, keep your clothes on physical. So the diagnosis, if no problems are found, are typically those Z codes where they say with no abnormals, no abnormal findings or abnormalities. Whereas if there are problems or abnormalities, we'd have to identify through separate ICD-10 listings what those signs, symptoms, or even definitive diagnoses may be. What can they and can they not address? They can address everything and anything they possibly want. And I'll be honest and tell you that annual wellness visits provide probably the best opportunity for us to gather information for patients and their conditions as it relates to quality reporting and meeting quality reporting and incentive based thresholds. So this is a great time to get those category 2 codes. And I think it's a perfect time to address literally everything, but it does not require a physical examination per se outside of vital signs. How should they document it? Kind of like I just said, I mean, if you get into the assessment and plan and there's nothing that was actually done or addressed throughout the course of the encounter, I would say that it would probably go out with one of those without abnormal findings diagnostic codes, and we'd let the chips fall. If they have an active complaint, do we ignore that? Absolutely not. I would say that you handle that at the time of that visit and take advantage of the time that you have now for capturing all of that quality data, because that might be the best time for you to get it. And you can schedule follow-ups for that patient. I'm assuming that this is FQHC here too. If it were an IPPE and an RHC, this conversation would be a little different because they might be both separately reportable. But being specific to the annual wellness visit, this is a great question. Actually, it's a great 3 questions. But yes, I would schedule a subsequent visit if that is necessary. And of course, that's a clinical decision left up to your providers, certainly not to me. So thank you very much. And thank you. All right, Tina. Should we list all of the patient's chronic conditions on the claim when an IPPE or annual wellness visit is done? I say yes, because it is a great time. Again, I'm going to sound like a broken record. It's a great time for us to capture quality data that's necessary to meet performance thresholds and incentive thresholds. And I don't think that there's really a better time for the IPP and annual wellness than with the IPPEs and the annual wellness visits to list those diagnostic codes. They might all be perfectly stable, which could have an impact on the diagnostic code. But yes, they should all be addressed. And those diagnostic codes should ultimately be listed because that's going to help you considerably in terms of quality reporting initiative standards. So the answer is yes. Great question, Tina, but the answer there is yes. Next question here is, we were told for Medicare RHC to not use modifier 25 ever. When are the times you would not use it or when you would use it? I don't know how I want to say this as respectfully as possible, but the 25 modifier on an RHC claim is not going to have any impact on what you're paid or how you're paid. But from a correct coding standpoint, and that's where I live, correct coding states that we should use modifier 25 in one of 3 instances. If there is the decision for minor surgery on the same day that a minor surgery is being performed, I know that you're going to report both of those codes on the claim. The modifier 25 is what is used to say, hey, listen, this was the significant or separately identifiable visit that kind of resulted in the decision to perform that minor procedure. So I think it should be used in that case. It's not going to have an impact on your payment, but yes, I think it should be reported. And when would I use it? When would I not use it? I'm reporting modifier 25 when it is applicable to that, when it's applicable to that claim. I wish that I could be more elaborate on that, Cindy, but I really don't even know how to do it. I would never say never use modifier 25, but I understand someone saying, well, you don't have to use modifier 25 because it's not going to have an impact, good or bad, on the actual payment of the all-inclusive rate for the RHC. So while that's a great question, I really, I hope that answers your question there sufficiently. So patients can be seen for a regular or a sick visit on the same day as IPPE, but not the annual wellness visit. Carrie, is it Carrie? Yes. Carrie, if you are speaking from an RHC perspective, that is true. If you are speaking from an FQHC perspective, it's not true. But yes, for FQHCs, the answer is most certainly. Yes, the slides will be shared. I'm not sure about the recording, but I'm hoping that maybe I can get a copy of that recording when the time comes as well. Thank you. Excellent as always. Well, thank you for the kind words. It's beautiful. Could you repeat the requirements for the face-to-face? Yes. All right. So Thomas, great question. And I believe that's Dr. Muller. That name sounds familiar to me. But yes, in an RHC or FQHC for that matter, in Chapter 13 of the Medicare Benefits Policy Manual, one of the requirements for any payment coming at a PPS rate or at the all-inclusive rate for RHCs, anytime we're paid one of those all-inclusive rates, there must be a face-to-face visit with a core or a qualified healthcare practitioner. An RN does not qualify for that face-to-face, nor does an LPN or a medical assistant. It is reserved for those providers in Chapter 13 that are listed as qualified providers in RHCs, FQHCs, which are MDs, DOs, NPs, PAs, clinical nurse specialists, clinical social workers, psychologists who aren't performing annual wellness visits, to the best of my knowledge. So if there's not a face-to-face visit with a core provider, a qualified provider, it's not going to represent a separate document. Let's see here. Well, thank you, Jacqueline. Those are kind words. Great information. Yeah, I mean, Gina, I agree with you. I think that providers at the end of the day should really be responsible. Our providers are the ones that are responsible at the end of the day for what it is that is submitted on claim forms. I think that they'd want to have an idea as to what needs to be there. And it's just a matter of making it easy on them, and oftentimes, oftentimes I think that the use of templates for annual wellness visits and IPPEs in particular is super helpful and productive. And getting providers involved in the creation and the deployment of those templates and uses of macro language and documents, I think that it makes all the sense in the world, because the provider is going to be the ones in one way, shape, or form that are going to be completing much of that information. But I'd create templates for each, the annual wellness visit and the IPPE, where you are not able to close that particular template unless all of those documentational requirements that CMS promotes are carefully addressed. And if they're not, well, we know that something's left kind of open-ended. But I hope that answers your question there. I think every provider should have this information as well. All right.
John, did you see the question?
Yes, go ahead.
You see it. Go right ahead. That's
okay. So I'm looking at the question that came in basically right around 2 my time. And it says, can you clarify if we can see the patient for the annual wellness visit through telehealth? I'm not going to say that you can't. I'm not going to say that you can't. I just don't think that it provides the best opportunity. I don't think that it provides the best opportunity for you, A, to capture quality data. B, you're going to have to report that as G20. You're going to have to report that as telehealth, not as an annual wellness visit, right? And if you're reporting something through telehealth, the payment for that is not the same as the payment for your all-inclusive rate. So I think that the annual wellness visits, for that reason, among others, maybe, I'd have to pick into that a little bit, but I think that the annual wellness visits are those that should really be promoted and performed on site. It is a personal statement that I just said. I'm not aware of anything that says the annual wellness visit cannot be performed via telehealth, but I would suggest that it be performed in person for that reason, if none others. Can an IPPE, so this is Rianne, can an IPPE or annual wellness visit be billed by RHC if done in the nursing home by RHC providers? Yes. And you know why? Because section 40.3 maybe of Chapter 13 of the Medicare Benefits Policy Manual actually shows the location where covered locations where RHC and FQHC services are permissible. And they're permissible. The list is synonymous between FQHCs and RHCs. It is in the clinics. Part A skilled nursing facilities. So if it is a Part A covered skilled nursing facility, the answer is yes. A patient's home qualifies as a site of service. The scene of an accident qualifies as an approved location. Chapter 13 says that a patient's home or a qualified Part A recognized skilled nursing facility are potential FQHC or RHC locations. So the answer to that question, Rianne, would be yes. Um, Andrea, you're very welcome. Part of the rule here. All right, I see. Hello, Melissa. I see that. Yes, I'm looking forward to my first visit to Uvalde. That is next week.
I know
Um,
we're over time and just wanted to put that opportunity out there. If your team or your facility wants to attend that boot camp, ArchPro is providing a coding and billing boot camp for Texas A&M Health next week in Uvalde, Texas. It's free for enrollment. So please access that event list. We have a few seats left. Breakfast and lunch are provided. It's 1.5 days for critical access hospitals and 1.5 days for RHCs and FQHCs. That's the plug for the boot camp.
Thank you very, very much, Melissa. But I think that takes me through the balance of the questions. I don't see any additional, so I guess that I'll say thank you very, very much for having me. It's always a pleasure to serve the Texas A&M health community, and I certainly appreciate being a part of the future success over there. So I'll see you next week, but in the meantime, thank you very much for having me, and let me know if there's anything else I could do.
Thank you.
Okay, I do want to mention we do have some additional opportunities for one-on-one consulting. If you walk away from this webinar and you have lists of questions that come to mind, please feel free to reach out to us and we are happy to discuss that opportunity with you.
By all means, thank you very, very much.
Thanks, everyone. Thank you for joining us. Have a wonderful afternoon.
All right, y'all, you too. Thank you.